Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast. Today we're looking at a review article from the Korean Journal of Radiology, published in a 2025 issue.
The title is Effects of Computed Tomography Technical Parameters on Body Composition Analysis. It's a really timely topic.
It feels like it. Body composition analysis, or BCA, seems to be everywhere now.
It is. The idea of using routine CT scans, ones done for completely different reasons, to opportunistically measure muscle and fat is incredibly powerful. It's a huge source of data for research on things like sarcopenia and obesity.
But that's the exact problem, isn't it? Routine scans aren't standardized for BCA. They're optimized for finding a tumor or a bleed. So if you're pulling data from all these different scans, how do you know the numbers are reliable?
That's the central question this paper tackles, because the core of CT-based BCA is quantifying tissues based on their radiodensity, their Hounsfield unit values.
Right. You have a threshold for skeletal muscle, usually something like -29 to +150 HU, and another for adipose tissue, maybe -190 to -30 HU.
Precisely. And from that, you get key metrics. For muscle, it's the skeletal muscle area, or SMA, and maybe more importantly, the skeletal muscle density, or SMD. Lower density suggests fatty infiltration, a condition called myostatosis.
And for fat, it's typically broken down into visceral adipose tissue, VAT, and subcutaneous adipose tissue, SAT.
Exactly. But this whole system rests on the assumption that the HU values are stable. This review systematically unpacks all the technical factors that can, push those numbers around.
Okay, so let's get into it. Where do the authors start?
They start with the biggest and most common variable, intravenous contrast.
A very common variable in abdominal CTs. How badly does it skew the results?
Significantly, especially for attenuation-based metrics. The paper is clear that post-contrast images generally show greater skeletal muscle area and, even more so, greater skeletal muscle density.
So muscle looks bigger and healthier just because of the contrast?
In a sense, yes. The paper points to Figure 2, which shows a pre- and post-contrast scan of the same patient. The post-contrast image has a higher SMA, 93 versus 90 square centimeters, and the SMD jumps from about 39 HUs to 55 HUs. The whole histogram of muscle pixel values shifts to the right.
That's a huge jump. What about the adipose tissue? Does it get enhanced too?
It does, and the consequence is actually quite logical. The paper notes that studies have found significant decreases in measured VAT area post-contrast. One reported a 7.6% drop. You can see that effect in Figure 2, where the area goes from 88 down to 77 square centimeters.
That makes sense. If the contrast enhances the fat, it increases the Hounsfield units, so pixels that were previously inside the fat threshold get pushed above it and aren't counted anymore.
Exactly. The fat near vessels and organs takes up contrast, gets denser, and the segmentation algorithm basically stops recognizing it as fat.
Hold on. So with contrast, muscle looks bigger and denser, while visceral fat looks smaller but denser. That's a non-trivial set of changes. You can't just mix pre- and post-contrast scans in a data set and hope for the best.
You absolutely can't. The paper says the values are not directly interchangeable, even though they're correlated. One study tried to apply a simple correction, subtracting 7.5 HU from post-contrast muscle, but the authors caution that such a simple fix isn't universally valid.
Fair. Okay, so if we're stuck with contrast scans, does the timing matter? Like arterial phase versus portal venous versus delayed?
It does. The paper describes a pretty consistent pattern. As you move from the unenhanced phase to the arterial, portal venous, and then delayed phases, there's a gradual increase in both muscle area and muscle density.
So the longer the contrast has to perfuse the muscle tissue, the denser it appears.
That's the idea. Figure 3 in the paper illustrates this perfectly with a 4-phase liver CT. You can literally watch the histogram for normal attenuation muscle area, the NAMA, grow with each subsequent phase from 109 to 127 square centimeters. Meanwhile, the low attenuation area, the LAMA, shrinks.
And the fat, does VAT also change across phases?
Yes, and consistently. The review notes that VAT area tends to gradually decrease with delayed imaging. In that same Figure 3 example, the VAT area drops from 109 on the pre-contrast scan to 87 in the portal venous phase.
So a patient's measured prevalence of sarcopenia and visceral obesity could actually change depending on which phase you choose for your analysis. That's a major red flag for consistency.
It's a huge problem. One study they cite found that the prevalence of visceral obesity significantly decreased in later phases. The takeaway seems to be pick one phase and stick with it for any longitudinal analysis.
Okay, let's move to another major factor, radiation dose, starting with tube current.
Right, the MAS. The clinical push is always to lower the dose, which means lower MAS. But lower MAS means more image noise. How does that noise ripple through to BCA metrics?
I'd assume more noise means more variability, a wider spread of HU values.
That's exactly right. But the effect on the average value is inconsistent across studies. A phantom study cited in the paper found that reducing the tube current led to lower muscle attenuation. But a clinical study comparing low-dose PET CT scans to diagnostic CTs found the opposite, higher muscle density in the low-dose images.
So the noise can seemingly push the average HU value up or down. The net bias is uncertain?
It's uncertain. And the paper notes that histogram analysis of these low-dose scans reveals broader pixel distributions, which confirms that increased noise is a likely source of the variation. Figure 4 shows this visually. The histogram peak for the low MAS image is much wider and shorter than for the high MAS image. Interestingly, though, the area metrics in that specific example, SMA, VAT, SAT, were identical.
So the area can be stable, but the density metric is fragile. What about other studies on fat? Did they find the same stability?
Not necessarily. One study they highlight is particularly interesting. It found that CT images acquired with very low tube current time products had significantly lower VAT and SAT areas and lower attenuation compared to standard dose images.
So a lower dose scan could make a patient appear to have less visceral and subcutaneous fat. It's a pretty significant potential misclassification.
It is. It complicates the interpretation, especially when you consider automatic tube current modulation, or ATCM, where the scanner adjusts the MAS based on the patient's size. That introduces another layer of patient-specific variability.
So just reporting the reference MAS isn't enough because the actual applied MAS could be very different. The theme here is that hidden variables are everywhere. What about tube voltage, the kV?
This is another big one. Lowering kV is a common strategy to reduce radiation dose and enhance iodine contrast. But changing the energy of the X-ray beam fundamentally changes tissue attenuation.
And how does that play out for muscle and fat?
For muscle on contrast-enhanced scans, the effect is pronounced. Lowering the voltage generally increases muscle attenuation. The paper uses Figure 5, a dual-energy CT, to show this. At 90 kV, the SMD was 50.2 HU. At 150 kV, it dropped to 40.2 HU for the same patient.
That's a 10 HU difference just from the voltage setting. What about the area? Did that change?
In that example, the SMA was slightly larger at 150 kV, but this is where the paper points out a key discrepancy between phantom and clinical studies. In a phantom, lower voltage led to higher SMA, but in a clinical study with contrast, lower voltage led to a lower SMA. The presence of contrast material really complicates the physics.
Okay, now what about fat? How does kV affect fat measurements?
This is also not straightforward. Studies have found that fat attenuation actually increases at higher voltages, which might be due to complex physics. For example, one study noted that fat attenuation was significantly greater at 140 kV compared to 80 kV.
And the area measurements for fat?
They also change. Another study comparing 100 kV to 150 kV found that the SAT, VAT, and intermuscular fat areas
all decreased at the higher voltage.
So higher voltage can make a person appear to have less fat. When you combine that with the lower muscle density at higher voltage, you could be misinterpreting both muscle quality and fat quantity simultaneously.
Precisely. The effects are coupled and can be confounding. It really underscores the need to be aware of the protocol.
Let's talk about what happens after the scan is acquired, reconstruction algorithms.
Right. The classic method is filtered back projection, or FBP. But the modern standard is iterative reconstruction, or IR, which is much better at handling noise, especially in low-dose scans.
But IR has a reputation for creating a smoother, sometimes described as plasticky, image texture that seems like it would directly affect attenuation measurements.
It does. A phantom study found that SMA was consistent between FBP and IR, but the muscle density, the SMD, showed a small but consistent decrease with IR.
A decrease, so it makes muscle look slightly less dense.
Yes, on average. And most clinical studies have focused on ROI measurements in organs, not full muscle segmentation. One study did look at psoas muscle and paranephric fat. It found that with IR, muscle attenuation was unchanged, but paranephric fat attenuation was lower.
So again, we have a parameter that affects muscle and fat differently. That seems to be a running theme.
It is. The authors also flagged that the strength of the IR algorithm matters. Most vendors offer multiple levels of IR, and higher levels mean more smoothing and potentially larger effects on BCA metrics. And now we have deep learning-based reconstruction, DLIR, which is even more powerful at noise reduction.
And its effect on BCA is basically unknown at this point.
Exactly. It's an area that needs urgent investigation.
What about another fundamental reconstruction parameter, slice thickness?
Another source of variability. Thinner slices give you better spatial resolution, but also more noise. The effect on BCA seems to be mixed.
How so?
A large clinical study of nearly 10,000 scans found very strong correlations for SMA and SMD between 1.25 millimeters and 5 millimeter slices, with only very small average differences.
Okay, that sounds reassuring.
But other smaller studies found more meaningful differences. One reported that 5 millimeter slices had an SMD that was 11.6% lower than 2 millimeter slices. Another study found that LAMA, the low-density muscle area, was significantly overestimated in thicker slices.
So thicker slices might make muscle look more fatty or steatotic than it really is.
Potentially, and for fat, the story is similar. One study found thinner slices had lower attenuation in all fat compartments. It also found that VAT and intramuscular fat areas were larger in 2 millimeter slices than in 5 millimeter slices, while subcutaneous fat was unchanged.
This is getting complicated. Every single parameter seems to pull different metrics in different directions. Let's talk about the hardware itself, different scanner types.
The review focuses on advanced scanners, particularly dual energy CT and photon counting CT.
Dual energy CT, or DECT, is interesting because it offers a potential solution to the contrast problem, virtual non-contrast images.
That's the promise. You do one contrast-enhanced scan at 2 energy levels and then computationally subtract the iodine signal to create a VNC image. This avoids the radiation dose of a true non-contrast, or TNC, scan.
So can VNC images substitute for TNC images for body composition analysis?
The evidence suggests not perfectly. The paper cites a dual-source DECT study where VNC images from multiple phases were compared to a true TNC scan. In all cases, the VNC images had significantly different SMD, SMA, LAMA, and NAMA values.
In what direction?
VNC images tended to have lower muscle density and higher muscle area. Figure 7 shows this clearly. The VNC histogram is shifted to the left compared to the TNC histogram. The SMD dropped from 45.7 to 37.4 HU.
What about fat on VNC?
The VNC images showed significantly higher attenuation for both SAT and VAT compared to true non-contrast. But the area measurements were similar or had only minor differences. So the density is off, but the area might be acceptable.
So VNC isn't a magic bullet. It introduces its own systematic bias.
It seems so. And other studies report inconsistent results, which might be due to different scanner technologies or contrast protocols. The bottom line is that institutions probably need to validate VNC for BCA in their own environment before using it as a replacement for TNC.
And what about the newest technology, photon counting CT?
PCCT offers even better energy separation, which should, in theory, lead to more accurate material decomposition and better VNC images. However, the research is very new, and the results for muscle have been inconsistent. Some studies report higher attenuation in TNC than VNC, others report lower. The methods are still being worked out.
So this review paints a pretty daunting picture of variability. What's the way forward? How do we make CT-based BCA more reliable?
The authors conclude with several future directions. The most effective solution, of course, is standardization in prospective studies, using the same scanner and a fixed protocol.
But that's not feasible for the millions of retrospective scans already in our archives, which is the main appeal of opportunistic BCA.
Exactly. So for retrospective or multi-center studies, the next best thing is explicitly reporting all the technical parameters to characterize the data's heterogeneity. Beyond that, the real frontier is in post-acquisition harmonization.
Meaning using software to correct for these differences after the fact?
Yes, this could involve using a common phantom to calibrate scanners across different sites, or it could involve physics-informed correction schemes that model how attenuation shifts with changes in KV and patient size.
And I assume deep learning has a role to play here.
A huge one. The authors mentioned deep learning-based harmonization, where an algorithm learns to translate images from one protocol, say a low-dose scan from one vendor, to look like a standard dose scan from a target vendor. It's like a universal translator for CT images.
That sounds powerful, but also risky if the model introduces its own artifacts.
It's a definite risk, but the goal is to reduce variability and improve the comparability of results. The authors make it clear that we're moving from an era of ignoring these technical factors to actively recognizing and trying to correct for them.
So the bottom line is, CT-based body composition analysis is a powerful tool, but it's far more sensitive to technical parameters than many of us might have assumed. For anyone using this data, awareness and consistency are paramount.
That's the key message. The measurements are not absolute. They are shaped by the physics of how the image was created. Acknowledging that is the first step towards more robust and reproducible science.
An important lesson for a rapidly growing field. That's all the time we have for today. Join us next time on SummaryCast.